I'd like to thank SAGES for this opportunity to present my work. Today I'll be discussing complex HPB surgeries in American community. Does it meet the standards of academia? I have nothing to disclose. My objectives today are to go over the current standards of hepatobiliary surgery, to look at my own personal experience in community practice, as well as our data from our institution, and then look at limitations of community-based practice. So I think the real crux of everything lies on that when we look at academics versus community practice, there is a perception that there is a superiority in hepatobiliary. And I think currently the superiority comes from an academic standpoint, as I do think most research comes out of these centers. However, my hope today is to show you that I think that actually community-based practices are doing a lot of volume and are probably similar and have similar outcomes to academia. So how do we define standards for hepatobiliary complex surgery? I think I'd like to draw your attention to my first citation, and Dr. Torzilli wrote this paper in 2021 looking at the effects of volume of outcome of hepatobiliary surgery, and defined his own guidelines and made a proposal. And while most of his research is done through Italy, I think that it can be used in the United States as well. So it is well known that volume of both the surgeon as well as the hospital affects both mortality and morbidity of patients. And so the higher the volume, the more likely that the risk for the patient does go down. But I think it's interesting that hospital volume also plays a role, and that's looking at kind of the resources, the ICU, the cardiac anesthesia. These are things that play a role in outcomes when we look at community practice. I also think it's going to be really important that we have hepatobiliary trained surgeons as well as surg-oncs that are competent and familiar with doing surgery on the liver and the pancreas. I think as the training hours have decreased and our specialties have been going towards more organ-based fellowships, I think that you're going to see a rise in hepatobiliary and the need within these groups of within these specialists for groups of hospitals. We also want to look at minimal hospital requirements. I think in order to do good hepatobiliary surgery, you must have excellent interventional radiology as well as advanced GI. If you don't have these things 24 hours a day, I think it's going to be really hard to have a high volume program, which defines success, I do believe. I also think that currently multidisciplinary team approach to cancers of the hepatobiliary system are essential. And I think that having this expert group of specialists improves care for these patients. But I think the truth of the matter is that you can see in this graph here that by 2030, the rate of pancreas and liver cancer is going to increase in the United States. It's going to be the second and third leading cause of death. And so the true important thing to take away from this is that I think that both community-based practice and academic practice are going to be essential in the future. And I think it's defining what excellent care is. So I would like to give you a little look into my personal practice. I work in Spokane, Washington at Providence Sacred Heart Hospital. This actually is a very large hospital. It's the second largest in the state. It is a level 2 trauma center, and it has 644 beds. We currently serve a population of about 2 million patients within the inland Northwest. I think for anyone to do great hepatobiliary surgery, you need to have an excellent team. And I think that that same team approach you see in academia is still present in community practice. You have to have confidence in your partners as they cover on the weekends. And I think in our practice-based model, my partner Juan Mejia started the practice in 2013, and since then has only seen growth. We have another partner who does mainly transplant. I do think mid-level providers do bridge the gap that we may see from learners at an academic institution, and she is an essential part of our team. But I think one of the things is how we maximize surgical quality in a community-based setting. And, you know, we are doing complex surgeries. We are doing our own vascular reconstructions, arterial constructions, Whipples, liver resections. And I think the thing that has helped us efficiently is that we have a dedicated OR team to hepatobiliary. Our scrub techs know exactly what the procedures are and what the next step is. We also have a 2-physician assist for hepatobiliary, meaning that I assist my partner and he assists me. We found that this has decreased time of the operation, as well as allows us the opportunity to get more cases in one day. We also share the same postoperative protocols. I think as surgeons at a university, you can have very differing views, which I think as a learner is excellent. But when you're trying to streamline care, I think having the same ERAS protocol, the same antibiotics, it makes it much easier for nurses on the floor or for people on your care team. We also have cardiac anesthesia, which allows us to do major liver resections, vascular occlusions if we need them, and they're excellent team members. So as far as volume, which I think I have defined as what I would say is what defines excellent hepatobiliary complex surgery. And I think you can see here from 2014 to 2020, we did 1,143 malignancy cases for hepatobiliary. And you can see the cases broken down. But if you look at the pancreas cases, we're doing about 70 pancreases a year. When you look at the number of Whipples per year, in 2018, we reached our height of about 60 a year. As you can see in 2020, as expected, our numbers were down due to COVID, but we are projected to be higher than 2018 this year, as we've already done 50 Whipples in 2021. So I think the other thing that community care is very good at is knowing its audience. And so our community-based center lives in a rural population. Most of our surrounding areas do farming. This means that a lot of our patients don't have a lot of the extra means to travel 4 or 5 hours to an academic center. It also means that sometimes the city can be overwhelming for these patients. You can see our median salary in our area is about $59,000, which is lower than the average mean of the United States, which is currently around $65,000. So these things matter when you're in community care because you're serving the population in which you live. One of the other things that I think makes community care special is that we have additional resources to actually go out into the community. And this may be one of our biggest assets. So all our patients who live over 2 hours away, we have 4 outreach clinics, which we go to once a month. And patients love it. We go to their community and we see them preoperatively and postoperatively. It saves them time, money, and they're very appreciative. And it also gets us into their community and helps us get to know their oncologist, their radiation oncologist, just a little bit better. I think both academia and community care can have outstanding tumor boards, and I think it's an essential part of being a standout in hepatobiliary, especially malignancy. We have weekly meetings. Usually we've been doing Zoom over the last 2 years. We have about 20 to 30 people who show up every week for these conferences. And I also feel very strongly about a GI pathologist. I think it really changes the way our pathology is read based on whether it's margins or the amount of nodes, or just knowing, is this cholangio? These are things that are very important. I think we also have in the community program time to focus on things that we feel our community needs. This is something we started over a year ago. It's the prehabilitation program. We partnered with one of our local physical therapy inpatient clinics. And here we get our patients on neoadjuvant chemotherapy into these rehab clinics, and they go once a month, and it's almost like their own personal trainer as they go through chemotherapy. We also have a nutritionist that helps us get these patients on high protein diets and work with them nutritionally. Perhaps one thing that I did not have in academia is a nurse navigator, and I will tell you it has changed the way that we practice. Patients love nurse navigators. There's someone to walk with them. They can answer questions, especially when I'm not as available. Something we've implemented this year is neoadjuvant therapy telephone calls. So many of our pancreas cancer patients are on neoadjuvant chemotherapy for 4 to 6 weeks or 4 to 6 months. And Melissa, our nurse navigator, calls every month to check in, see how things are going. It also helps us forge a relationship through Melissa with our patients, that we care and that we are following along with them during this journey. But I think the hardest thing for community practice is to stay up to date and to force yourself to stay relevant within the field. And I think where academia has more of a push to stay in because of the learners, I think community practice, you are forced to stay up to date. You must advance with the technology. My partner and I really put a lot of effort into maintaining our robotics. It's currently making up about 40% of our practice. And we feel like this is the future. And so we are continuing to forge forward with it. As far as continuing to assess and reassess what you're doing right and wrong, I think this is the crux of a really good program. And so a year ago, we got NSQIP. We review it quarterly, and we make changes based on what we're seeing. And we review the literature, and we are trying to decrease certain complications. We have really used this data to help improve our outcomes. But I think what's really most important is knowing your limits as a community hospital, because you can't do it all. And I think, you know, if I could say one thing about our institution that I wish we had more of is clinical trials. And so, you know, I have taken it upon myself. I know I have every list of HPB clinical trial within a major university with 4 to 5 hours on my board at work. And that way I feel like, you know, when patients are failing first line, we have other options for them that I can send them to. But, you know, also knowing the things that you're not doing, like I'm not doing HIPEC, and these are things that have to be, you know, sent out to a bigger institution. I'm also not doing HAI pumps, and these are other things that I think that, you know, you have to know what's out there in order to get patients to what they need. But what I hope today that I was able to show you is that HPB malignancies are increasing, and that utilization of community practice is going to be important in the future. I actually think that good community HPB care goes on all over this country, as well as in academia. And I think that what we should really be focusing on is not making it a community versus academic problem, but really looking at the volume of which these institutions are performing and how many patients are actually getting surgery there. I think each program, whether academia or community practice, have its strengths and weaknesses. And I think that's what makes the United States interesting, that patients have the option to choose what they would like. And with that, I'm going to conclude, and I'd be happy to answer any questions.